I'm Dr. Fischberg from Queens Medical Center and the John A. Burns School of Medicine. Now, I just want to be sure everybody is in the right place. We're here to talk about palliative care. We're going to actually be spending some time reviewing the official definitions of palliative care, but I just wanted to cover some short phrases. This is our elevator definition of palliative care: specialized medical care that treats the symptoms and stress of a serious illness. And the goal is to improve quality of life. Now, if it's a really short elevator ride and you really maybe should have just taken the stairs, palliative care is living as well as you can for as long as you can. And I think really the most pithy definition of palliative care I've ever come across, I'm going to take it right from one of our heroes, Dr. Ira Byock. He titled his last book, The Best Care Possible. And for me, that's what palliative care is. It's the best care possible when you have a serious illness. Now, we're going to talk a lot about what palliative care is. I just want to talk a little bit about what palliative care can do. And so I'm going to start with a story. And this is a patient, Bobby, I'm going to call him, changed his name and his age, but everything else is really straight from the medical record. And Bobby was cared for by colleagues of mine here at Queens in our outpatient palliative care program. Bobby was 58 and he had recurrent lung cancer. He'd gone through cancer surgery, radiation, chemotherapy, but despite the best efforts, the cancer came back. And he had terrible pain. His oncologist, his surgeon had been working really hard, really doing a good job trying to control the pain, but they just weren't getting the results. And that's what prompted the referral to palliative care. So he had severe pain refractory to their treatments. He had a terrible cough and shortness of breath, which we call dyspnea. And because of this, the cancer being back, his pain, his breathing problems, he was really depressed. And on top of this, his functional status was really plummeting. He was pretty much living in a bed or a chair. And my colleague, the day he met Bobby, he told me he thought this was a fellow that was maybe a week or two from a hospice referral for end-of-life care. So what was the first thing they did? Well, they tried some co-analgesics. The other doctors had been using opioids, and moderate dose opioids were not effective. So they used some things to target the inflammatory component of the pain, the neuropathic component of the pain, and it started to help. And then he got big relief when they switched his opioid to methadone, which can be a uniquely helpful pain medication. And with that, with his pain better, his mood improved. He didn't actually need treatment for depression, just treating his pain, his mood got better. And by the third visit, they were able to talk about his goals of care. Bobby desperately wanted more time with his family. He was going to pursue active treatment. But at the same time, he was willing to engage with the palliative care team and talk about hoping for the best and planning for whatever. So they did complete a POLST provider order for life-sustaining treatment document, and Bobby expressed his wish to avoid heroic measures. He did not want a resuscitative attempt. He did not want to be on life support. So the POLST said DNR, limited interventions. Then Bobby initiated immunotherapy, and I would say it was an understatement of the year to say that he had a robust clinical response. His cough, his breathing problems, they completely resolved. His performance status got much better. He pretty much got back to doing all the things he could do before the cancer. In fact, things got so much better, his pain was completely relieved by the effective cancer treatments that he came off of all of his pain medicines, no more methadone, not even Tylenol. 5 years later, Bobby has no measurable disease. And with that, they actually reevaluated his goals of care and they did a new POLST. He's full support now, and he actually no longer requires routine palliative care follow-up. So I show this story to show that palliative care, it's not end-of-life care. It's best integrated early on with active treatment and really can be that added layer of support that helps people get through that active treatment, even potentially for a curative approach. I just want to, quote another one of our heroes in palliative care. And Diane Meyer recently, when she was speaking about expanding access to palliative care, and particularly about how to integrate palliative care throughout the healthcare system, Diane said, it's not about prognosis, it's about need. It's about relief of suffering, and it's everybody's job.